of our CURE program since it began a few years ago. Dr. Melissa Nossal is a seasoned clinical psychologist and executive leader with 18 years of experience in behavioral health care. She earned a Bachelor's of Arts in Psychology from Slippery Rock University, a Master's of Arts in Clinical Psychology from Regent University, and a Doctor of Psychology degree from Regent University. Dr. Nossal seamlessly integrates her profound understanding of psychology into her strategic leadership approach, characterized by an unwavering dedication to excellence, quality care, and genuine concern for the well-being of patients and colleagues. With nearly a decade of directing inpatient psychiatric programs at UPMC Western Psychiatric Hospital and Torrance State Hospital, Dr. Nossal integrates clinical insight into operational leadership, drawing on her extensive experience in leading acute psychiatric programs. Currently serving as the Vice President of Behavioral Health Services for Pittsburgh Mercy, Dr. Nossal directs 50 ambulatory programs delivering care to more than 12,000 individuals annually throughout the greater Pittsburgh area. And if that isn't impressive enough, Dr. Nossal is also a consultant and speaker for the National Council for Mental Wellbeing and works to actively advance mental health practices and policies on a national level. So I'm so excited to turn it over to Dr. Nossal.
Thank you, Dr. Stott, so much for having me. I'm very excited to be able to share on this call. All right, so today we're going to talk about the Integrated Community Wellness Center, or ICWC, which is a comprehensive model of coordinated behavioral health care. If we could go to the next slide. We are going to go through who we are here at Pittsburgh Mercy, the CCBHC model, or Certified Community Behavioral Health Clinic model of care, which is a federal demonstration offering 9 core services to make sure that there is access to integrated coordinated care for the people who are in need of behavioral health care in our communities. I'm going to speak to the history of the model and the expansion, which significantly increased around COVID. I'm going to talk a little bit about funding and criteria. How do you even become a certified community behavioral health clinic? And Pennsylvania's CCBHC journey, as well as adaptation into the Integrated Community Wellness Center model of care. We'll speak to our specific ICWC here and our care coordination efforts, as well as some of the regulatory and reporting requirements that are a little bit different for ICWCs and CCBHCs versus other more traditional licensed models of care that are licensed under OMSAS and DDAP under the state of Pennsylvania, and then speak to some of the challenges. And then we will open it up for discussion, questions, and if you guys have questions along the way, feel free to put them in the chat. The team is happy to jump in and let me know, or you can hold them to the end. Either is completely fine with me. Next slide, please. Okay, so who are we here at Pittsburgh Mercy? Most of you on this call probably are from the general kind of the greater Pittsburgh area, so you're probably fairly familiar with us. We are a large health and human services organization here in the greater Pittsburgh area. We are almost entirely in Allegheny County. And we have the same roots and the same legacy as Carlow University. So we were also founded by the Sisters of Mercy who came over from Ireland and really have that same mission, where our goal here at Mercy is to reach out and offer help and hope to some of our community's most vulnerable people and populations. We have an annual operating revenue of about, it's actually 115 million, I'm told, as of last week from the calendar year data from last year. And we serve about 18,000 people every year. Across behavioral health services, it's about 12,000 people that we have the opportunity of providing service for every single year. All over Pittsburgh, 57 locations. It's actually 111 unique addresses. So we are pretty prevalent around Pittsburgh. We have 1,000 colleagues here at Pittsburgh Mercy, and we are a certified community behavioral health clinic, or were, and you'll hear about that. We also received 3 different SAMHSA certified community behavioral health expansion grants. We're on our 3rd iteration, and this one I believe is $5 million. We have a fair amount of different buckets under the Pittsburgh Mercy umbrella. I do like to just speak a little bit about who we are, because oftentimes I don't think people fully understand the kind of the breadth of services that we have. Mercy Behavioral Health is about half of our services. We also have a legacy brand of Operation Safety Net, which is our street medicine team under Dr. Jim Withers, where they go into the camps and provide they provide different services, street medicine to individuals. We actually started street psychiatry recently too, which we're very excited about, and make sure that people that are in the camps and in the community that that don't have housing are receiving medical care. We own and operate the large shelter downtown, Second Avenue Commons, the 92-bed shelter. We work in conjunction with University of Pittsburgh Medical Center, who has a clinic in there in order to support our people. We actually have a small behavioral health clinic over there also. Bethlehem Haven joined our team back in 2017, so they are under our umbrella as well. Bethlehem Haven is a women's shelter and medical respite program, amongst other services that they have. We also have the entire care continuum of intellectual disability services, housing, companion services, day programs. We have our own pharmacy and health center, and we own McCully Ministries. McCully Ministries is a grant-making organization and foundation that's actually housed in Carlos still, so you may be familiar with McCully Ministries. When Pittsburgh Mercy sold Mercy Hospital to UPMC back in 2008, they used the proceeds to create a grant-making foundation, and they have been able to already give away over $55 million to folks in our community. So we're very excited that we've been able to continue Catherine McCully's legacy in that way, which is very exciting. Next slide, please. All right, so let's talk about the CCBHC model of care. Well, what is the CCBHC? You guys might have heard this is becoming more prevalent. Talking about certified community behavioral health clinics. Well, this model is designed to ensure that there is access to comprehensive and coordinated behavioral health care to anybody that might need that level of care. It's really a behavioral health home model of care where we should be able to provide, the CCBHC should be able to provide whatever care is needed for that individual within a certain number of core services. And individuals should be able to kind of weave in and out of different services as they are needed. So if somebody needs IOP, and then maybe they only need medication management only, now they need service coordination, certified peers, or maybe they need crisis services. Based on need over the lifespan, we should be able to provide most of those core services through the CCBHC model of care in conjunction with primary care. So there is this focus on integration with and coordination with primary care as well under the CCBHC model. Next slide. So what are the priorities? Well, there are specific core priorities for all CCBHCs under the federal demonstration. One is ensuring access to care. Is there access to integrated care, evidence-based care for substance use disorder, mental health, and crisis services? Key. And access is not access in a month, access in 3 months. Is there easy access? Is there open access? And the metric really is, can we get them in within 10 days? That is kind of the gold standard that we're really reaching for with the CCBHC model. Increased quality care. So there are robust reporting and quality metrics around the CCBHCs regarding staffing, regarding access, regarding also coordination. So that's another high priority target there. Sustainability. This is one of the areas that's very different with the CCBHC model, and that is this is a financially sustainable model. There's a lot of outpatient clinics out there, especially those that accept Medicaid, that are not able to be financially sustainable. This model changes that. It allows for you to include all of the costs, including those non-billable costs for services, into a cost report, and then you are actually reimbursed based on that cost report, and the state determines a rate, and that's what you get for the services. So it is a sustainable model of care delivery, which is one of the things that made this very, very different as well. Increased partnerships. We have to have partnerships with local stakeholders, with the county, with the state, with your managed care organizations and different partners to make sure that we are providing that strong care delivery system. And there is a strong focus on reducing recidivism, also decreasing hospital admissions and readmissions, and decreasing bed days also. Next slide, please. So what's the history here? Well, the CCBHC model and federal demonstration has been kind of going on for a while. Since 2009, there was an Excellence in Mental Health Act that introduced the federal financial support of access to this quality, high quality care for mental illness and for addiction. Then in 2014, they created really the CCBHC model and decided which states were going to be in the initial federal demonstration to see, is this even going to work? Does this model even make sense? So initially in 2016, there were 8 specific states that were invited to participate in the federal demonstration. And that included Minnesota, Missouri, New Jersey, New York, Nevada, Oklahoma, Oregon, and our state here, Pennsylvania. Then in 2017, states launched their demonstrations. We did 2 here in Pittsburgh Mercy, and there were 67 CCBHCs across all of these states. Then in 18, Congress funded 2 more years of CCBHC expansion grants, allowing new sites. Now, the expansion grants are different than the certified community behavioral health clinic. Sometimes people get those confused because you can have a CCBHC expansion grant, but that doesn't necessarily mean you're a certified clinic. So it's important to know the distinction there. Next slide, please. Then in 2020, there was a fairly substantial change where it was decided federally through the CARES Act that there was going to be $200 million released to allow for more CCBHC expansion, which was huge. As we all know, what was going on around this time, COVID really hampered people's ability to access care. There have been these significant labor shortages and challenges. So there was additional funding that was put out there to make sure that this model was available and that people could access service. Then in 2020, 166 awards, expansion awards were provided, and in 2020, 2 more states were also added to the demonstration, which included Michigan and Kentucky. In 2022, it was decided that every 2 years, 10 states will be able to be added to the federal demonstration. And then last year, 15 more planning grants were awarded to different states. And then this year, it was proposed, and what was put through was that 10 additional states could be added to the federal demonstration as well. Next slide, please. So this gives you a nice image. You can kind of see where the CCBHCs, the CCBHC expansions, and anybody that has CCBHC funding is, and this is as of March of 2023. So if you can see, this is everywhere. It's all over the country, and there's only 3 states really at this point that don't have any representation in the CCBHC realm, and that includes the Dakotas and South Carolina. Next slide, please. So why does this matter? Why is there so much of a focus on the CCBHC model of care? What are the outcomes with the CCBHC model of care? Why does this matter? Well, the National Council for Mental Wellbeing put together an impact report back in 2022 to share what they're seeing according to the statistics, how this has been positively impacting people and their access to care especially. So what they found was that in 2022, there was an estimated 2.1 million people being served across 450 CCBHCs, which is huge. So there's a lot of people that are receiving access to care. And that was a significant increase from 2021, where it was 1.5 million. So that's pretty significant. What they found, though, was that there were more people that were increasing capacity in their clinics. There are people increasing capacity in their caseloads in some ways because some of the regulatory burden and some of the different pieces of what everybody has to do when they're doing these services were able to be supplemented with other positions to kind of streamline things. It opened room for caseloads to be a little bit more. What they found was there was a 77% of the clinics said we have been able to increase our caseload capacities. And what they found was there was on average 900 more people being served at CCBHCs. After they were able to get this different funding model, which is a 23% increase. So that's pretty significant. There also was a significant increase in access to medication assisted treatment specifically, and different types of medication assisted treatment. Next slide, please. Let me talk a little bit about the funding, because the funding for CCBHCs does look different than the traditional fee-for-service model that we see in more traditional ambulatory care. So CCBHCs receive an enhanced Medicaid reimbursement rate through a prospective payment system, and this is cost report based. So what the clinics can do is they can look at what are all of my costs to provide this service, from the leases of my building to different care coordinators to billers, to everything that goes into providing this service, and all of these services, how much does it actually cost? And that is what is sent to the state. And then they use that to determine a rate. And that rate then is what is drawn down when people come in for service. So each CCBHC ends up with a unique rate of reimbursement. Everybody's different because everybody's costs are different. You even just think about our area. If I was operating a clinic in Shadyside, my costs for even rent are going to be very different than if I was operating a clinic in McKees Rocks. So its costs are different, and we understand that. And so they really wanted to look at that and make sure that costs were covered in this model of care. Now, there were two different methodologies of payment. One is a PPS daily rate, the other is a monthly rate. And what that means is after it was all said and done, they have all the costs, they look at how much everything costs, and then they determine through an analysis what makes sense. If somebody comes in for care, they get a set rate. So any day they come in, it's the same, whether they come in for service 1, service 2. There's 9 core services that I'm going to go over in the CCBHC model. Regardless of what service they come in for, it would be the same rate, and that would be for that day. So that was one option. Another option is a monthly rate. So that is if somebody comes in one time for a service, or if they come in 25 times, maybe they're in psychiatric rehabilitation and they're here 5 days a week, and then they have psychiatry, and then they have outpatient therapy. That person, and what we would draw down from a funding perspective, is the same monthly rate as we would draw down if it was somebody coming in just once that month. So those were two very different kind of methodologies behind how you would be funded. And this is all through, well, in Pennsylvania, through Health Choices dollars. It's paid through Medicaid specifically. So it does. It's variable. Most states did the daily rate. We initially did the daily rate also, and then it switched over a little bit later in 2020. So I'll share about that in a little bit. Next slide. So what are the certification criteria? Well, one is staffing. So we need to make sure that there's a local needs assessment that's looking at how many staff are actually needed, what is the volume of patients that are going to be coming in, and how do we meet that need in our community. So local needs assessment, there's licensing standards and such also for us that's dictated most often by OMSAS or DDAP or some of the other licensing bodies, to see what staffing complement do we actually need. Second is that availability and accessibility to service. Do we have a standard access? Do we have methods for engagement? Is there crisis services? Are we taking the patients that are in need of care, not cherry picking, oh, we want to serve this person or this person, but making sure that there's equal access for everybody that's in need of care. Coordination. This is one of the cruxes of the model. Is there coordination not just amongst your own internal services, which is a huge part of the model, that all of the core services are kind of interwoven and coordinated, but also are we coordinating between our services and higher levels of care, between our services and other behavioral health services, and even between our services and other community programs. The scope, we need to make sure that there's all 9 core services that are being offered within your CCBHC program, or there has to be a DCO agreement. And what that stands for is a designated collaborating organization that has agreed to provide one or more of those services. In 2023, the CCBHC certification federal criterion changed. And one of the things that changed was they said, if you have this certification, if you're a certified clinic, you have to provide at least 51% of the CCBHC services in-house, or else you don't qualify to be certified as a clinic. So that was something that changed that hadn't been specified before. From a quality perspective, there are 21 different quality measures. There's quality improvement, specific measures, lots of program requirements around making sure that the quality is up to the standard of the CCBHC model. And then there's organization, authority, and governance. Is there consumer representation in the governance of the CCBHC program? Do you have state accreditation? And this is beyond just licensure. Obviously, your programs have to be licensed, but also, do you have, whether it's Joint Commission accreditation or CARFID accreditation, you have to have a separate accreditation also that's looking at the quality of your program to be able to qualify to get a CCBHC certification. Next slide, please. So what are these core services? In the CCBHC model, there are 9 core services that we look at and that have to be provided within the model. One is initially coming in the door, screening, assessment, and diagnosis and risk assessment for anybody that's in need of this type of mental health care. Outpatient mental health and substance use services, that also includes medication-assisted treatment. That's also very important to have as an offering within the CCBHC model. Targeted case management, or what we know here in our area as blended service coordination. Outpatient primary care screening and monitoring. And this is within the clinic, and this can also be in conjunction with primary care. Also access for veterans and veterans to be in services. That's another big push, making sure that our veteran population is being taken care of. Certified peer specialists, making sure that there are peer specialists that are available to provide services to our patients, and then psychiatric rehabilitation as well. Lastly, crisis services and treatment planning. That's pretty standard for any level of care. But having access to crisis services, and not just any crisis services, but they want the kind of the open access crisis services, but then you have to have mobile crisis services either in your program or with a designated collaborating organization in order to qualify for this model. Next slide. So Pennsylvania did things a little bit differently than a few of the other states in the original demonstration. We did get in 2016 the Excellence in Mental Health Demonstration Planning Grant to be a certified community behavioral health clinic demonstration state. But there was a lot of questioning around funding. The funding was not secure, especially pre-COVID back in 2019. And there were times where it was just, a couple of days or a couple of weeks in advance, and it wasn't sure, federally, is this money coming down? And Pennsylvania decided there's just too much risk. We're not going to continue. The funding is not clear. We don't know if this will continue. And this is, it's a new model of care. We don't even know how effective this model of care whereas at this point, the model had only been around since 17, and that's when everybody had just started. So there wasn't a whole lot of good data even on the model yet at that point. So in 2019, Pennsylvania decided to leave the initial demonstration, and that was very challenging for all of the certified community behavioral health clinics. If you think about it, the CCBHCs developed a different type of programming that allowed for supplemental services that were not billable to help support that model of care delivery. Well, now we're going back to fee for service. So all of that had been built in over the last several years was no longer able to be covered. So for Pittsburgh Mercy specifically, we were the largest CCBHC. We still are the largest ICWC in Pennsylvania. That decision cost us about $5 million. So that was pretty significant and pretty concerning. And it really affected our ability to allow for access to care. So there was a lot of advocacy from us, from other from other CCBHCs that had lost their certification when Pennsylvania left the demonstration, and lots of conversations with the state and local stakeholders around this model. And after it was really kind of thought through, Pennsylvania decided, okay, we do see this value. We see the value in this model of care. We want to continue this type of service, but we are going to do it a little bit differently. Pennsylvania sometimes likes to do things a little bit differently. So Pennsylvania decided that they were going to take that same model, they were going to tweak it just a little bit, and they were going to rebrand it as the Integrated Community and Wellness Center, or ICWC. So sometimes we use CCBHC and ICWC interchangeably because it's really ultimately the same model of care, but it is a little bit different because the ICWC is unique to Pennsylvania specifically. And a couple of things that changed were, one, when we moved to the from the CCBHC model to the ICWC model, governance changed. So instead of that, the federal, being a federal demonstration, it was run really by the states. The state then punted oversight locally. So then it became the counties and the Medicaid MCO that was really the oversight, behavioral health MCO, that was the oversight of all of the ICWCs. We also switched the payment methodology, and that switched from a daily rate to a monthly rate. So it kind of revamped. We had to revamp our whole billing structure around that, as did the other ICWCs across the state of Pennsylvania. Next slide, please. So this is the map, just so you can get a general idea. All of the 7 CCBHCs are still active as ICWCs across the state of Pennsylvania. Nobody's closed. We are the only one really in Western PA. As you can see, Allegheny County, number 5 over here. We have 3 that are in the eastern side of the state, 1 in the north, and then St. Clair actually has 2 because they cross counties right on that county line of Jefferson and Clearfield. So those are the current CCBHCs that were converted to ICWCs. Now, this is different than the CCBHC expansion and planning grants. There's lots of people that have those across the state of Pennsylvania. Having those does not mean that you're eligible to become a certified community behavioral health clinic or an integrated community wellness center. With the change into the ICWIC model, it really made it so that new CCBHCs or ICWCs could not get that status of being CCBHCs or ICWC programs. Although interestingly, the state has expressed that they are interested in potentially expanding those programs. So more to come there. We're excited to hear that there may be some changes, or there may be access for other providers to be able to offer this model of care delivery, which would be exciting and allow for more access and the financially sustainable model of care delivery. Next slide, please. So let me share a little bit about us here at Pittsburgh Mercy. As I had shared, our ICWC is the largest one in the state of Pennsylvania. We offer 85,000. Well, this is from 2022. We had 85,700 total services within our ICWC program. We had 5,100 members over the course of the year, and so we were able to offer care to a lot of different individuals who were in need of these different levels of service in our community. Next slide, please. So I'm going to break down what we offer specifically here. And we do have the opportunity to offer all of the ICWC or CCBHC services with the exception of one. So we offer 8 of the 9 core services. The mobile crisis is a county contract that is only given to one provider, and that has been given to UPMC Resolve Crisis Network. They do a phenomenal job with mobile crisis, and we work directly with them to make sure that our ICWIC persons served are able to get their services, their mobile crisis services need through Resolve, and they've been a great team to work with. We do have 24/7 walk-in crisis services also, and we do have now a licensed crisis residential site within our Central Recovery Center, which is on our South 9th Street campus, and people can come in, get assessments, get referrals. We have a 12-bed program over there that we're able to offer those services also. So that's our crisis mental health services. We have a plethora of behavioral health outpatient services through our admission center, where we have open access hours Monday through Thursday. People can come in off the street, get an assessment. If we have already filled all of our assessment slots for that day, we're able to schedule those out. And really, we do focus on making sure that people that have Medicaid have access to services, because oftentimes there's more challenges in having and in them having access to care. So we really do try to make sure that we prioritize people that have Medicaid in getting access, but we can accept all kinds of different insurances here at Mercy. Our South 9th Street outpatient clinic is our largest clinic. We also have a justice informed program at our Gatehouse location, which is in the South Side also. And that is a program that is for folks that have a history of sexual offenses that have been court ordered. We are the only Medicaid provider in our area for folks that have a history of sexual offenses to receive treatment. Everybody else is most of them are set up a little bit different, like commercial insurance or whatnot. So, but we do specialize in that Medicaid population. We have 3 different contracts with city schools. We are in 3 different school districts, 37 different schools. We offer school-based treatment through our ICWC, also office-based and psychiatry within the ICWIC program. And we have a mobile team that is able to go out in the field if folks are not able to come on site and receive services in their home. One of our personal care homes is actually licensed also, and we do psychiatry over at Garden View Manor, which is in Wilkinsburg. And not too long ago, we were able to also open a satellite clinic at our shelter, 2nd Avenue Commons, where we're able to offer outpatient therapy. Every week we do psychiatric assessments at 2nd Avenue Commons, and we're able to do initial assessments too, to make sure people that are over there have access to care, and we have folks that can coordinate them to benefits and such. So we are very working with folks that are unstably housed is very much in line with the mission of Pittsburgh Mercy, and we try to make sure that as best as we can, we get them into care if they're interested in receiving, whether it's primary care or behavioral health care. We also recently opened a small clinic within our Bethlehem Haven shelter, so that is coming down the pike as well. Next slide, please. So we do the primary care screening and monitoring, which we're able to do from our South 9th Street primary location, but also we have a primary care clinic right there that we work very close with, and we can work closely with other primary care providers. It is a very important quality metric also, making sure that ICWICs or CCBHCs are working closely in conjunction with primary care. We offer substance use services. We have kind of the more traditional substance use disorder outpatient. We have IOP. IOP is open and accepting referrals, so please feel free to refer to us. We also offer medication assisted treatment now through the ICWC. Previously, we had only done MAT through our primary care clinic, which was good to have access that way, but it did mean that folks, especially folks that had Medicaid, they had to have us as a PCP in order to get services there. That is not the case anymore. They can just come into our MAT clinic and get treatment there. We also have a Clozaril clinic. People are welcome to be a part of also if that's necessary. We have service coordination, blended service coordination, including specialty teams for hearing and deaf services. We have specialty teams for forensics, adolescents, lots of different specialized patient populations. And we actually have carved out 2 of our service coordination teams specifically for internal ICWC referrals to make sure that at any time our folks within the ICWIC have access to service coordination. Very important. We have certified peer specialists and mobile teams that can go out in the community and provide peer support services wherever people are. So we very much value that service. And then we have 2 different psych rehab offerings. We do the more traditional psych rehab for severe and persistent mental illness, but then we also have a specific group for folks that have a history of forensic or legal involvement, and for folks that have a history of sexual offenses. Sometimes they want to be with folks that have similar history. There's a lot of stigma associated with that. So that is another offering that we have here within Pittsburgh Mercy. Next slide. All right, so as I've said several times, one of the really high priority targets within the ICWC is care coordination. And this is, I would say, a challenge. I think traditionally, especially because of the way licenses are structured, care is often very siloed. I'm in service coordination. I have a care plan. Here's the treatment plan, and it's over here. Okay, now I have psychiatry. I have a treatment plan, and that's over here. And then maybe I'm in also now I'm in group, and I have a plan, but kind of there's not coordination, at least not significant coordination. Everybody's kind of doing their own service separate. And that's one of the things that this model really wanted to get away from. And I'll say it was a little bit challenging, especially at the beginning of moving towards this model. How can we coordinate care effectively? And how do we have a more integrated care plan? And that was one of the challenges too. And we've worked with our stakeholders, Allegheny County, community care, and I think we're all on the same page with the goal being, if we had an integrated treatment plan for the ICWIC, that would be amazing. But that is not really possible because there are different licensing requirements for each and every program and service. So there's a different frequency for service coordination care plans than there is for SUD treatment plans, than there is for the traditional mental health plans. So everybody's got different regulatory requirements within their care plans and treatment plans. Everybody has a different frequency that they need to be completed. And so that gets a little bit tricky. So we were really looking at, okay, well, how do we take that and take some of these challenges and then come up with the best path forward to make sure that we're getting truly coordinated care? We also had the opportunity to have a lot of care coordination within our record, but that we used it so much that it broke that part of the record. So we realized that's not going to work. The volume was too much, and we had to kind of think through other ways of doing that. But I was really happy to see that there was so much care coordination happening through the record. So one of the things that we changed, having the admission center, not just the admission center for outpatient, which I think was how we had it set up initially, but also having that be the admission center for all of the ICWIC, and to make sure that it services the whole ICWIC program. So if somebody comes in, they can walk in off the street, come in and get an assessment. From the first week of care, we will have a treatment team on every single person, whether it's through the admission center, whether it's through our walk-in crisis center across the street. and have representation from all of our our ICWIC service teams to make sure that we're reviewing cases. Do we make the right recommendation for the level of care? Hey, we recommended these 3 levels of care. Make sure that you know this person's coming. So we have those conversations every week from the onset of somebody coming into services with us. We also really tried to focus on making sure that, yes, we have care coordination. We're having conversations anytime that's clinically necessary or appropriate. But anytime we have a care plan, anytime we have a treatment plan, we have those targeted coordination efforts so that we have our goals that are aligning. One of the things that we saw was, this person talked to the PO, but then this person talked to the PO, and this person talked to the PO. Well, why are 3 people talking to the PTO just because they're or PO just because they're in 3 different services? That doesn't make sense. That's a kind of a duplication of a service in a sense, and a duplication of a goal. So we wanted to get away from that. How do we make sure that our service coordinators and our therapists and our psychiatrists and our certified peer specialists aren't duplicating services? Well, that's through these coordination efforts. So we are making sure that we are sharing goals, what we're working on prior to any new care plans or treatment plans. And one of our goals, and this is probably, we're going to be at least 6 months out for this, but one of our goals is to have those auto-populate in the record too for all of the different ICWIC services. So that's the future IT requests that'll be coming down the pike, but we're excited about that. We also have engagement care managers. Do you mind going back? Thanks. We have engagement care managers. This is one of those supplemental positions that isn't a billable position, but it's really needed to make this model work with how we do this at Pittsburgh Mercy. And we focus on, okay, who are our high utilizers of ICWIC services? Who was recently discharged from a 24/7 level of care, whether it's inpatient or a residential or a crisis service? Who had crisis services recently? Who's at increased risk? We're always looking at risk and doing risk assessments, and what's the clinical need, and making sure that we're getting those treatment teams scheduled when there is need, and they're kind of the grease, I would say, in between the different levels of care here within the ICWC. We also, as I kind of have given a couple of examples, needed to make sure that our record was working for us. We made sure that there was designators for care coordination meetings, kind of getting that all on the record, because as we all know, in behavioral health and mental health, if we didn't document it, didn't happen. And so we wanted to make sure that there was the ability to document, and that there was the ability for both synchronous and asynchronous care coordination. With the times changing, now there's hybrid options. People are in the office, people are working from home. How are we making sure that we are still able to coordinate all of these efforts? Next slide, please. So we were able to make some pretty significant record adjustments so that we could pull out episodes of care coordination. This just looks at basically a 1-year period of time across the ICWIC, and it shows that there were over 12,000 instances of care coordination for our 5,000 persons served that we have over the course of this time period. So we're really glad that we're able to kind of make the record work for us in a way that we could demonstrate in conjunction with the other clinical documentation when we are coordinating care. Next slide, please. And this slide I thought was really telling because it shows when we made the change the first quarter of 2023, this was March through January through March of 2023, when we moved towards having those communications prior to all care plans and treatment plans, and making sure there were those significant coordination efforts around those, we saw this huge jump up in our care coordination efforts and those that were involved in the care coordination meetings, as opposed to how it was set up before. So lots of efforts. We never get there, I will say. We're always trying to improve and trying to move things forward, move the needle, making sure that we are serving the people that we have the privilege of serving to the best of our ability every day. We're always tweaking, we're always growing, and we're always open to feedback and how we can do things a little bit better. Next slide, please. So as I had said, within the ICWC model, there are pretty substantial reporting requirements within this model. This is a little screenshot from what's called Innovasor. Over the last few years, we actually moved a lot of our key performance indicators and what we were looking at in regards to kind of fiscal goals and quality goals into a new population health software where we were able to have nice dashboards where it kind of showed us how we were doing from a quality perspective, from a fiscal perspective, and then also look at some of our ICWIC measures to make sure that we were on track. So this is just a little screenshot. One of the key priority areas that we look at from a clinic-led measure has to do with depression screening and follow-up, making sure that we are always following up if somebody has been diagnosed with major depression. It's one of the key focuses. So there's robust reporting requirements within the CCBHC model. In the ICWC model, we have clinic-led measures, state-led measures. We have to submit files of all of the persons that we serve throughout the calendar year. And then there's pretty significant quality standards also. Next slide, please. So some of the measures have changed recently. There was a focus more on physical health. So we were looking at BMI, we were looking at weights, we were looking at tobacco cessation, alcohol screening. Suicide risk obviously is something that's really significant for us to always be looking at, clinical depression and remission. But this changed in 2024. So fresh off the press, now the state really wants us to be looking at time to service. And I don't think anybody is surprised because there is a huge access problem when it comes to behavioral health care. And we want to make sure that people are able to get into services. And that goal is within 10 days is really the goal. They're looking at social determinants of health or social drivers of health. And then we're going to keep on looking at depression and unhealthy alcohol use as well. Next slide, please. On the state measures, some of them are fairly consistent with the clinic-led measures where we're looking at depression screening, we're looking at initial wait time. We're also looking at not just initial wait time, like how long does it take to get an assessment, but how long does it take to get from the assessment to the actual mental health service. So that's also important too, another area that we're looking at. We're looking at veteran referrals, also telehealth patients, how often is this happening, and what are the locations. We're looking at the folks and number of people that are receiving substance use disorders. We're looking at specialty providers and really they're targeting some of their attention on peer support specifically. Next slide. Okay, and then lastly, we have pretty robust quality standards that we follow. These are the CCBHC standards. Some of these, as I said, had changed back in 2023. Some of the CCBHC certification criteria changed. Some of this changed also, but it just kind of takes it up to the next level. What they're looking at in regards to different levels of care within the ICWC. So they're making sure that we're always looking at all the level of care recommendations within the ICWIC and maybe recommendations for other services outside of the ICWIC. They want to make sure we're always looking at suicide risk, trauma, substance use disorder, the social determinants of health, making sure we're always coordinating with those different levels of care, from the 24/7 levels of care or other levels of care that aren't necessarily within our ICWC. Treatment planning, this is not different than other places where it needs to be person-centered. You need the patient involved, but we need to make sure that we are having those really significant coordination efforts with crisis services. That's one of the focuses there. Are we doing education around medication, diagnosis, and so forth? Next slide, please. And then care coordination, kind of the crux of the model right here. Are we coordinating with families? Are we coordinating with personal supports if they're not as involved with their families? What about the PCP? Are we coordinating every year at least with the PCP? Are we coordinating with our own within the ICWIC and outside of the ICWIC? Are we coordinating with education? Like if somebody's in school, are we coordinating with work if that's something that is clinically necessary? What are the social determinants of health, and are we focusing on making sure people are connected and linked with community-based services as they're needed based on the SDOH assessment. Discharge, this is not unlike other places, with the exception of how do we get back into services, how do we re-engage within the ICWIC, and how do we have access to emergency crisis services if needed. I think this is pretty standard in the field. And then making sure all of the documentation is completed as required. Next slide. Okay, so this comes to the end of the presentation. We reviewed kind of the history of CCBHCs, Pennsylvania's adaptation, and what we do here at Pittsburgh Mercy within the CCBHC and now the ICWC model. One of the things that I wanted to speak to very briefly is some of the challenges, and I did speak to this just a little bit. One being regulatory requirements, that they make it a little bit tricky within the ICWC model to make sure that we can have a truly integrated care plan. Back when we were a certified community behavioral health clinic, the state actually got our different licensors together and they audited us as an ICWIC. Yes, we still needed to make sure all of our licenses were in good standing, but they would make sure that DDAP and OMSOS and everybody were on the same page and making sure they were looking at us like an ICWIC, not just like separate programs. And that did go away. One of the other challenges, and this has recently changed, which I have to give the state of Pennsylvania kudos here, and that is that we lost technical assistance. So being a certified community behavioral health clinic included a lot of technical assistance to make sure that we were doing the model correctly, that we were documenting things correctly, that we were measuring things correctly and consistently with other CCBHCs, not just across our state, but across our country. And one of the things that changed was when we were no longer a CCBHC, we lost that assistance. And the state did not provide that for us. National Council has the contract to do a lot of the CCBHC technical assistance, and we have had the opportunity to work for them. They've been really great. But Pennsylvania realized recently that that has actually been a disservice to the state, and they have reinstituted technical assistance for ICWC programs across the state. So we're very excited about that. You know, they're looking at our numbers and everything that we're now sharing with the state and sharing federally, like here's how we are in comparison with the other ICWICs or the other CCBHCs, where we can compare data. There's areas where we can't, which is another one of those challenges. But we're able to work now towards getting on the same page with how we're all collecting data to make sure there is consistency across, because it's not very meaningful if I collect my data this way and I use these definitions of how I'm collecting this data and this other ICWIC does it completely different. Then you're comparing apples and oranges there. So that's not really helpful. We need to make sure that we're using, you know, the same definitions of how we're in the same standards there. And then there has been inconsistency in regulatory oversight, although I think we've been able to get a little bit more on the same page with our local stakeholders. They've been working very closely with us and been very helpful. But there has been a challenge because we are still trying to adhere to all of those same CCBHC quality standards, whereas that is not consistent amongst the ICWICs. So we've been working closely with the state and our local stakeholders there. And then because PA has changed some of our reporting requirements, so it doesn't always match the federal reporting standards, we can't necessarily compare our data. We can compare across ICWICs, but we can't compare it with other CCBHCs. So it's hard to know, is this model better? Is it not better? We don't know because we can't really look at the data as we would be able to if we had still been in the federal demonstration. But even so, we do very much see the value of this model of care and the importance of having this coordinated care offering with really open access. There were a lot of challenges within COVID in making sure that folks did have access, and we were able to make a lot of changes internally to make sure that we could increase access, even though there were some of those challenges. So that brings me to the end of my presentation. I know we only have about 5 minutes left. I know you probably want to go to the end to the QR code, but if anybody has any questions or comments, I would love to hear those now.
There was one question in the chat from Elizabeth, and I'm just going to read it. It says, "Thank you. If a CCAR has a veteran individual that I have been helping now that he has moved to Pittsburgh, how can I give a reference? Should I check by zip code facility?"
You can just call our main line and put together an appointment. One of the things I will say though is if it is somebody that has Medicaid, we do need to have in-state Medicaid. That's the tricky piece. So there are these pieces because we are a little bit different from the FQHC model. And I'm hoping that the CCBHC model does move in this direction, where we really can provide access to anybody. We can provide access to most, but we cannot provide access to all. Like folks that don't have eligibility to have, Social Security cards, folks that are undocumented that are being seen in FQHCs, they are able to bill and provide those services. That has not been fixed yet in the CCBHC model. I will say, though, that we have been advocating for maybe looking at things a little bit differently. It is all through Medicaid that we draw down those dollars for those reimbursement rates. So if it is somebody that's not that doesn't have Pennsylvania Medicaid, it is a little trickier, but you can go ahead and give us a call and we'll see if we can connect them. If we can't take them to another service, so they're able to get services in our area. That's very important. I know that's probably not the answer that you wanted, but we can also help them get PA Medicaid. So we have folks that can help work with people on that.
Thanks. Another question is if participants are able to get a copy of the slides so that they could share them with others. Is that okay with you?
Oh, absolutely.
All right, we can share that in a PDF format if that's fine. And then I think there's one more question from Troy. It says, will the funding be renewed to continue the services, or was the funding for startup capital?
So we are continuing. We are all this former CCBHCs that are now ICWCs are funded. That is continuing. We are staying with the ICWIC program in the state of Pennsylvania. There is not currently the ability for new providers to become ICWICs, but Pennsylvania has said they want to change that. So there's been a lot of discussion around is Pennsylvania going to rejoin the demonstration, which I would advocate for. I think that there's a lot of value. There's also federal matching dollars that we could get as a state that we are, I think, missing out on because we are not in the demonstration right now. So there's been a lot of conversations around rejoining, and that may happen. There was one other state that left that rejoined the demonstration, and I'm hoping we move in that direction. Even if we don't, Pennsylvania does see the value, and they want to look at possibly moving in the direction of being able to add ICWICs. They did share. We don't know what that means. We don't know the timeline. Pennsylvania is not often fast, I will say. These things are not fast, but programs do have the ability to look at the CCBHC planning grants and potential they're able to get federal funding that's not through the state if they are interested in kind of looking towards this model of care. So that can be another avenue that you can apply for through SAMHSA.
Thanks. And one last question in the chat from Troy. Will addiction counselors be able to receive supervision hours if they work within this program?
So I am a licensed psychologist. I will say I'm very committed to making sure that everybody that works here at Pittsburgh Mercy, to the best of my ability, is able to get supervision hours for licensure. We very much value that. We now give an enhanced the minute you get licensed, if you have a billable license, whether it's an LPC or an LMFT or an LCSW, we make sure that we give you an immediate salary bump. So I just need to know that you got that license. We check it, and then you get that increase. So we very much value folks staying with us and continuing on their career, and then helping to provide licensure supervision for kind of the next people coming in. So we've recently kind of revamped our structure over the last year to make sure that we can do that a little bit better. But we do offer LPC supervision. We offer LCSW supervision. We only have a handful of LMFTs, but we do have those too. So even if it's not within one program, and then we have some of the substance use certifications. We have a couple of people that have those too. So we do our best to make sure that we pair people, even if it's from other programs. We have 50 behavioral health programs, so we are lucky in that because we're so large, we can kind of put people together to make sure people get what they need. LPC supervision is extremely expensive, and so we do everything we can. I can't 100% guarantee it, but I can say we do everything we can in-house to provide that for the people, for our colleagues that work here at Pittsburgh Mercy.
Great. Well, thank you, Melissa. As always, such a wealth of information. We appreciate you taking the time to talk with us today. And I'm going to turn it back over to Sophie or Bethany to tell you about the survey.
Did everybody have any difficulties accessing the links that were shared in the chat? So there's the sign-in link, which is step 1, and then at the end you take the survey. Please let me know if anyone needs those, and I'm happy to reshare them. And then once you're done with the survey, when you get that thank you screen, just make sure you take a screenshot and send that to socialwork@carlow.edu, and we can get you your continuing education credits. We usually turn those around in about 3 to 5 business days. So I'm going to share the email. But yeah, thank you all for joining.
Yes, thank you for coming.
Not seeing any other questions in the chat, so I'll probably just leave it open for a couple more minutes here just to make sure everyone has received the links, and then we'll close from there. Thanks again.
I hope everyone has a great rest of their day. I'm going to end the meeting. Thank you all for coming. I hope you enjoyed this presentation, and I hope it's not too snowy where you are. Bye.